Welcome to Population Health Nursing. Up to this point in your nursing education, you've been trained to think about care at the individual level. One patient, one diagnosis, one treatment plan. But today, I want you to shift your thinking. Instead of asking what's wrong with this patient, we're going to start asking what is happening around this patient that's shaping their health. Because health does not begin at the hospital, it begins in the communities, environments, and systems. And as nurses, if we don't understand these systems, we will treat the same conditions over and over again without ever changing any outcomes. Let me introduce you to someone we will follow throughout this lecture. Miss Johnson is a 52-year-old. She has diabetes and hypertension. She lives in rural Georgia. She works part-time and struggles with consistent access to care. Now, at first glance, this sounds like a straightforward chronic disease case, but I want you to keep asking yourself what is really driving her health outcomes? Is it a lack of knowledge? Is it poor compliance? Or is it something bigger? Throughout this lecture, we're going to build a deeper understanding of her situation, and by the end, you should be able to identify not just her illness, but the systems influencing her health. Let's start by making sure we're all familiar with the key terms and what they mean, because these concepts build on each other. I pulled these definitions from the beginning of chapter 1 in your textbook. Public health is a broad concept focused on the overall goal of promoting and protecting the health of all people in the communities where they live, learn, work, and play. So this is the big picture. This is the systems level views, policies, prevention, strategies, and environments that influence health. The term public health nursing builds on that foundation. It integrates nursing, public health, and social services, and focuses on promoting and protecting the health of the population. So, as nurses, we're not just caring for an individual, we're thinking about groups of people and factors that affect their health outcomes. And then the term public health nursing interventions. These are the actions that we take to address problems and improve the health of populations. So, some interventions might include health education, community programs, resource referrals, and policy advocacy. The term population health focuses on the health outcomes of a defined group of people. These groups share characteristics such as a diagnosis, like diabetes, or a location, such as rural populations, socioeconomic status, and key strategies include tracking health indicators like A1C, blood pressure, identifying trends and disparities, and understanding social determinants of health. So again, key question, what's happening to this group and why? Community health is more specific. It focuses on a particular place or a group of people, often defined geographically or culturally. It involves local organizations and partnerships, culturally appropriate care, and community specific interventions. Key question here is what is happening in this specific community and what resources or barriers exist here. So, putting it all together, it's important to understand that public health sets the overall mission and direction. Population health uses data to identify problems and disparities. Community health applies interventions at the local level. And a public health nursing specialty is how we bring all of this together in practice. As a public health nurse, we're going to focus on both population and community health. We're going to use epidemiologic data. We're going to apply ethical principles of the greater good, and we design interventions based on evidence and data. So let's apply all of this to our patient, Miss Johnson. To truly understand her situation, we have to look at her health from multiple perspectives. We view our patient, Miss Johnson, through the population health lens, which is a broad view. We're going to be looking at what is happening with diabetes in rural Georgia overall. We're going to be looking at trends. higher diabetes rates in rural areas, for instance, or disparities such as income, access, and outcomes. We might look at health indicators like A1C levels and complications. This helps us understand Miss Johnson is part of a larger at-risk population. And then if we look at Miss Johnson through the community health lens, which is a more local view, we're going to zoom in and think what is happening in Miss Johnson's specific community. We consider transportation barriers, limited healthcare providers, food access, and local resources. This helps us understand what barriers and supports exist in her actual environment. As nurses, we bring both perspectives together. We use population data to understand risk, and we use community knowledge to guide interventions. And then we apply interventions that improve outcomes for both individuals and groups. If we only look at Miss Johnson's A1C level, we are missing the bigger picture because her diabetes is influenced by where she lives, what resources she has access to, her income, education, and her environment. Public health is going to give us the big picture. Population health shows us the patterns. Community health shows us the environment. And public health nursing connects it all to the care for patients like Miss Johnson. So where you live has a direct impact on your health. Even within Georgia, different counties have different levels of access to care, resources, and opportunities, as you can see listed on this slide. Now think about Miss Johnson's rural environment. Limited healthcare providers, longer travel distances, and fewer specialists. Possible transportation challenges. So her health outcomes are not just about managing blood sugar, they're about access. So I want you guys to think about what is one barrier that Miss Johnson may face simply because of where she lives. Now we're going to give a name to these barriers. You've learned about these in previous classes, so it's social determinants of health. These are the conditions that people live with that influence their ability to be healthy. In Miss Johnson's case, income may be affecting whether she can afford her medication. Education level affects her understanding of disease management. Living environment affects access to healthy food and safety. The key point here is that health outcomes are largely shaped outside of the healthcare setting. Determinants are organized into 5 domains that are listed here. So we're going to apply each to Ms. Johnson. First up, economic stability. Can Ms. Johnson afford insulin or her blood pressure medications? Education. Does she understand how to manage her diet? Healthcare access. Can she get to her appointments? Neighborhood. Are healthy foods available? Social and community context. Does she have support? As nurses, this is how you start thinking differently. Not just what treatment does she need, but what barriers are preventing her success. This visual is showing how the factors surround the individual. So take Miss Johnson. We'll put her at the center, but everything around her affects her outcomes. If we don't address the surrounding factors, her condition will remain uncontrolled. This is why education alone is not enough, and even medication alone is not enough. We have to address context. For example, instead of she has diabetes, these factors help students answer, why is her diabetes hard to control? First up, childhood experiences. She may have grown up with poor nutrition, limited healthcare access, and these have possible long-term impacts, such as increased risk for obesity and diabetes, learned health behaviors such as diet and exercise. Context here is her disease didn't start today, it has a lifespan of influence. Next factor is health is housing. Rural Georgia housing may include limited access to grocery stores. We call this a food desert. Unsafe area for exercise, lack of refrigeration for insulin in some cases. Her environment may directly impact her diet and her medication management. Third factor is education. Lower health literacy can affect understanding of carbs and relationship to insulin, medication adherence, recognizing complications. So, not non compliant, she may be lacking knowledge and tools. Social support, number four, and that's whether or not she has family helping with meals, someone to remind her about her medications. In rural environments, isolation is common. So diabetes management is harder when you're alone, which can lead to poor outcomes. So having support equals better outcomes. The fifth factor is family income. Limited income affects their ability to buy insulin and supplies and healthy foods versus cheap processed foods, and also transportation to appointments. Financial barriers equal real constraints, not necessarily choices. Employment for the sixth factor. Job types may influence their ability to attend appointments. Maybe they can't get off work to go to the doctor. Access to insurance, time for meal planning. Work schedules may conflict with self management routines. Seventh factor is community. For instance, rural communities may have few clinics, limited diabetes education programs. They might have a strong faith-based network, however, and this could be a very important resource. So just think in context where a patient lives shapes their available support systems. Access to health services. So in Miss Johnson's case, she lives in a rural area. So there are rural barriers, long travel distances for healthcare, fewer specialists like an endocrinologist. There's limited pharmacies. Putting this into context, poor control may be due to access, not necessarily motivation. Okay, so let's talk a little bit about Healthy People 2030, which focuses on creating social, physical, and economic environments that promote health. These are some of the objectives, and we call these objectives upstream drivers of health. They're not medical care itself. So let's apply each of these specific Healthy People 2030 objectives to Ms. Johnson. First step, we have reduced children with a parent who has been incarcerated. Why this matters. Children with incarcerated parents are more likely to live in poverty, experience instability, and trauma. And if we put this in Miss Johnson's context, if she had this childhood experience, she may have grown up with limited stability, uh, higher lifelong stress, we know leads to increased risk for chronic disease and learned survival focused behaviors such as diet and health neglect. Connection to diabetes also is that long term stress plus poor early health foundation is going to lead to increased diabetic risk and poor control. So, her diabetes may reflect her life trajectory, not just her current choices. Number two is reduced proportion of people living in poverty. And why this matters is because economic stability directly affects health outcomes. In Miss Johnson's case, if she lives in poverty, she might not can afford insulin and supplies. She may rely on cheap, high carb foods and delay care due to costs. Connection to diabetes, we know that poor glycemic control increases complications. Poverty is limiting her ability to improve self-care, possibly. The third objective from Healthy People 2030 is increase employment in working age people. And this matters because employment is tied to income, insurance, access to resources. And in Miss Johnson's case, if unemployed or underemployed, She may not have insurance, which could be the reason for the inconsistent care. It also causes financial stress and irregular routines. Missed medications, poor adherence to diet and exercise. Key insight here is employment equals stability for chronic disease management. Fourth objective is increase children living with a full-time working parent. This matters because it reflects family and economic stability during childhood. And in the case of Miss Johnson, if she lacked this, she would be at greater risk of unstable housing, food insecurity, and limited exposure to structured routines. And the connection is poor early health behaviors can lead to lifelong chronic disease risk. And this ties directly to childhood leads to adult diabetes risk. We learned that in our endocrine lectures last semester. The fifth objective is reducing families' spending greater than 30% of income on their housing. And this matters because housing costs affect financial flexibility for health needs. In Ms. Johnson's case, if most of her income is going to housing, then she has little left over for medications and transportation, as well as healthy foods. So, competing priorities. Health is often deprioritized. In other words, she may be choosing between insulin and rent. The sixth objective is increase high school graduates enrolling in college. This matters because education improves health literacy, job opportunities, and the ability to navigate the healthcare system. If Ms. Johnson has a lower education level, she may not, again, understand carb counting, medication timing, complication, and warning signs. The connection here is she may appear non-compliant, but actually is experiencing a knowledge gap. Education shapes the ability to manage your disease. The final objective we're going to touch on here from Healthy People 2030 is the increased federal data sources. This is country of birth, etc., and why this matters. Data helps identify disparities and target interventions. So in the context of Ms. Johnson, her situation becomes part of population health data, and this leads to resource allocation. Without the data, rural diabetes disparities stay hidden. So the big idea here is what gets measured gets addressed. The critical point I want you all to understand here is using Ms. Johnson's situation helps us understand that Healthy People 2030 objectives demonstrate her diabetes is influenced by upstream social determinants such as poverty, education, housing costs, and employment. These systemic factors create barriers to medication adherence, healthy nutrition, and access to care, which contribute to poor diabetic outcomes. So let's talk a little bit more about Healthy People 2030. Again, the Healthy People 2030 is a major national public health initiative. It's a science-based 10-year plan designed to improve the health and well-being of all Americans. It provides directions for where healthcare and public health efforts should be headed across the country. What's important for you as for future nurses is that this initiative doesn't just give us general ideas, it gives us specific measurable goals that guide what we do in practice, education, and policy. First, we have the core objectives. Healthy People 2030 includes 359 measurable objectives, and we just went over a few on the previous slide. Each has a specific target and timeline. These help track national progress. Now let's connect this to Ms. Johnson. So think about her situation, whether it's managing chronic conditions, improving sleep, or addressing lifestyle factors. As nurses, we align our care with these national goals. For example, if Ms. Johnson has hypertension, we're working toward national targets like improving blood pressure control rates. That means our interventions, education, medication, adherence, lifestyle, and coaching are not just individual care, they're part of a larger national effort. Next are developmental objectives. These focus on areas where evidence is emerging and where we're still building data collection system. In Ms. Johnson's case, think about newer or less clearly defined issues, maybe social determinants of health, access to safe environments, or technology use in managing health. We may not yet have strong national benchmarks for every part of her care, but we recognize these areas are important and evolving. As nurses, we still assess and address them even when evidence base is still growing. Then there's the research objectives. These identify gaps in knowledge where more research is needed before we can set measurable targets. This is where nursing becomes even more powerful. If we notice patterns in patients like Ms. Johnson, such as barriers to sleep, cultural influences on health behaviors, or challenges with adherence, those insights contribute to future research. Today's clinical observations can shape tomorrow's national health goals. So when you care for Ms. Johnson, you're not just treating a patient, you are contributing to the larger public health mission. We're using core objectives to guide evidence-based care, recognizing developmental areas that still need structure, identifying research gaps that will shape future practice. And this is how the bedside nursing connects directly to population health. Well, let's build on what we just discussed with Healthy People 2030 and talk about something that directly impacts patient outcomes. That's health disparities. Health disparities are differences in healthcare access and health outcomes between groups of people. According to Healthy People 2030, these disparities are closely linked to social, economic, and environmental disadvantages. And importantly, they tend to affect populations that have historically experienced discrimination or exclusion. So let's bring this back to Ms. Johnson. When we care for her, we cannot just look at the diagnosis in isolation. We have to ask ourselves what factors may be putting her at higher risk for poor outcomes. Who is affected? So this slide highlighted who is affected by health disparities. And as you can see, this includes groups defined by race and ethnicity, religion, socioeconomic status, gender, age, mental health, disability, sexual orientation, and geographic location. These are all characteristics that can be tied to differences in opportunity, access, and treatment. Now, let's think about Ms. Johnson again. Does she have reliable access to health care? What is her socioeconomic situation? Does she live in an area with limited resources? Each of these factors can impact her ability to manage her health. Now let's look at root causes of health disparities. These include poverty, environmental threats, limited access to health care, behavioral factors, and educational inequalities. These are not just individual problems, they're system level issues. For Ms. Johnson, this might look like difficulty affording medications, limited access to healthy food, living in an environment that increases stress or healthy risk, lack of health education or understanding of her condition. So when we see a patient that's not adhering to treatment, the question is not just why isn't she following the instructions? Instead, we should ask what barriers are preventing her from being successful. As nurses in the clinical setting, this is where your role becomes critical. You are not only providing care, but you're identifying disparities, advocating for the patient, and addressing barriers to care. With Miss Johnson, that might mean connecting her to community resources, providing education tailored to her situation, advocating for access to services, and using culturally competent communication. So the big takeaway is health disparities are not random. They are predictable, preventable, and tied to large social systems. And when you care for patients like Ms. Johnson, you are in a position to help reduce those disparities by recognizing the big picture, not just the disease, but the person and their environment. So I want you to take a minute and think about this. What specific disparity might be affecting Miss Johnson the most? And what is one nursing intervention you could implement to address it? All right, let's take a look at this image about equality and equity. It really captures the difference between the two in a powerful way. On the left side, labeled equality, you see the individuals given the exact same support. Each person is standing on one box. First glance, that seems fair, right? Everyone's being treated the same. But if you look closely, not everyone can actually see over the fence. So even though the treatment is equal, the outcome is not the same. Now, on the right side, we label this equity. Here, each individual is given what they need, specifically the need to reach the same outcome. Being able to see the game. So some have more boxes, some have fewer, and one person doesn't need a box at all. That's the key difference. Equity is not about giving everyone the same thing. It's about giving each person what they need to be successful. So let's connect this to the definition on the slide. Health equity means that every person has a fair and just opportunity to attain their highest level of health. But to achieve that, we have to actively remove barriers, things like poverty, discrimination, lack of access to quality health care, and limited education. So let's bring this back to Miss Johnson. If we provided Miss Johnson with the exact same discharge instructions, resources, and expectations as every other patient, that would be equality. But would that actually set her up for success? Let's think about her situation. Does she have access to transportation? Can she afford medications? Does she understand the teaching we're giving her? Are there cultural or environmental barriers affecting her care? If those barriers exist, then treating her the same as everyone else may actually lead to worse outcomes. So, as nurses, we practice equity, not just equality. For Miss Johnson, that might mean spending extra time on her education, using a different teaching strategy, connecting her with community resources, adjusting the care plan to fit her real life situation. Because our goal is not to treat everyone the same, our goal is to help every patient reach their best possible health outcome. So when you think about equity, I want you to remember this image. Equality is giving everyone the same box. Equity is making sure everyone can actually see over the fence. And then nursing, equity is what leads to better, more just patient outcomes, especially for patients like Miss Johnson. Okay, we're going to take another look at equality and equity. We're going to add in justice. We're going to start with the left image again, just for a review. Equality, this looks like the first picture, when everyone gets the exact same thing, the same support, the same resource, regardless of their need. And again, in this image, you see three individuals trying to watch a game over a fence. Each person is given the same box to stand on. It seems fair at first glance. Everyone's treated the same. But when you look closely, are all three individuals able to see the game? Who cannot see clearly? Exactly. The shortest individual still cannot see. So even though treatment was equal, the outcome was not equal. Connect this to Miss Johnson. If we used equality in her care, we would give her the same discharge instructions, the same follow up expectations, and the same resources as every other patient. But if she has barriers like transportation issues, financial constraints, or difficulty understanding the instructions, then giving her the same care as everyone else is not going to lead to the same outcome. Just like in this image, equal support does not guarantee equal results. Okay, so go to the middle. Again, we see equity. We recognize this that people have different needs. Instead of giving everyone the same support, we're going to give each different levels of support so everyone has an equal opportunity to succeed. So in this image, each individual is given different number of boxes based on what they need. And now all three can see the game. That's equity. So in the case of Miss Johnson, what would it look like for her to have equity? Instead of standard care, we might use the teach back to ensure understanding. We may provide simplified or visual education materials. We may arrange transportation or connect her with community resources. We might schedule closer follow-up or case management. Um, and then we might see that we're meeting her where she is. And this is what strong nursing care looks like, individualizing care to achieve equal outcomes. But one more concept, we're going to move to the right image, which is justice. Justice is not just about adjusting support, it's about changing the system. In this image, the fence is no longer a barrier. It's been redesigned so that everyone can see without needing extra support. The root problem has been addressed. Connect this to Ms. Johnson. So now let's ask a deeper question. Why does Ms. Johnson have these barriers in the first place? Is it limited access to healthcare in her community? Is it gaps in her insurance or affordability? Is it a transportation issue? Broader social determinants of health. Justice means we don't just help Ms. Johnson navigate the system, we advocate to fix the system. This might look like expanding access to primary care, improving discharge planning systems, addressing policy or community level barriers. So patients like Ms. Johnson don't need extra help just to receive basic care. So what's the government's role in public health? It lies in the role of decision making. But remember, these government decisions affect funding, programs, and access. Ms. Johnson's ability to access care is influenced by policies beyond the clinic. This is why nurses must understand systems. Okay, so let's look at a real world example of how policy and funding decisions directly impact health outcomes. This slide gives us two different examples, and it's very important that you understand that these two separate policy proposals both influence patients' health in different ways. And first, we have a proposal to increase funding for behavioral health workforce. This means that increasing the number of mental health providers, such as counselors, therapists, and psychiatric professionals. And this is important because many areas, especially in rural areas like where Ms. Johnson lives, have provider shortages. So if the funding were implemented, it could increase available providers, reduce wait times, improve access to mental health and substance use care. So let's think about Ms. Johnson. Even though her primary diagnosis is diabetes and hypertension, mental health still matters. Stress, depression, financial strain can all impact her ability to manage chronic disease. So, increasing the workforce could indirectly improve her health outcomes by improving access to care. In example two, we have a second example, which is the most critical one for this discussion. This proposal focused on providing housing and employment support for certain Medicaid patients. This is different from the first example. It's not about healthcare services, it's about improving the patient's living conditions. These supports could include help with stable housing, assisting finding or maintaining employment, and we already know that housing and income are major social determinants of health. Now, here's the key detail. This program would have cost the state $45 million. They would have had to be given a match from the federal government of $90 million, which all of this comes from taxes. So funding support would be available through taxes for a lot of money. But the proposal was removed and not approved due to cost. So let's apply this directly to Ms. Johnson. If the program had been approved, she might have had more financial stability, better access to housing, reduced stress, greater ability to afford medications, And all of this would lead to better blood pressure control, better diabetes management, fewer emergency room visits, but the program was not approved. Those supports are not available to her. So this slide is showing you something important. There are different ways to improve health. One is improve the healthcare system, or you can improve the patient's living conditions, and both matter. But here's what I want you to understand most. Policy determines which of these supports actually exist. So I want you to pause and think about this. Which do you think would have had a bigger impact on Miss Johnson's health? Having more providers available or having stable housing and employment? There's no single right answer, but you need to be able to think at both levels. So let's talk about something that many student nurses initially feel uncomfortable with, and that's politics in healthcare. When we say politics, we're not talking about personal opinion or a political party. We are talking about how decisions are made about resources. Because in healthcare, every decision comes down to what gets funded, what gets prioritized, who gets access. So politics determines who gets care and who does not. Now let's bring this back to Ms. Johnson. If policies do not prioritize rural healthcare, then fewer clinics will be built in her area. There will be fewer providers to practice in her community, and fewer resources will be available. So even though she needs care, the system may not be structured to support her. And this is where you come in as a nurse. You are not just a caregiver, you're also a patient advocate, a system observer, a professional voice. Even small actions like educating patients or speaking up in your workplace are forms of political engagement. Across all healthcare systems, three core issues drive policy decisions: cost, quality, and access. So let's break this down using Ms. Johnson. Cost. Can she afford medications, appointments, and transportation? Quality. Is she receiving evidence-based care? Does she have access to specialists? Access. Can she physically get to care when she needs it? Here's the challenge. Improving one often affects the others. For example, increasing access may increase cost. Reducing costs may impact quality. So policymakers have to constantly balance these three. Now ask yourself, which of these is Ms. Johnson struggling with the most? The answer is likely all three, and that is why population health requires looking beyond the bedside. Healthcare reform in the United States has historically occurred in small steps. This is called incrementalism. Major programs like Medicare, Medicaid, and the Affordable Care Act, which is an example of one of the largest health policy reforms in the United States, were all designed to improve health access to care, and they did make a difference. But here's what's important for you to understand. Even with the systems in place, gaps still exist. For Ms. Johnson, she may not qualify for certain programs. She may fall into coverage gaps. She may still struggle with affordability. So reform helps, but it does not solve everything. This is why continued advocacy is essential. This is where your role becomes critical. Nurses are often the first to see patterns, barriers, repeated issues. You're in a unique position to identify health inequities. For Ms. Johnson, you might notice missed appointments, uncontrolled conditions, financial stress, and instead of labeling her as non-compliant, you ask, what is preventing her from succeeding? That question changes everything because now you are not just treating a patient, you're addressing an, an inequity. So what does it mean to be politically active? Being politically active does not mean you have to work in government. It means staying informed, advocating when needed, engaging in conversations. For example, supporting access to care, educating communities, participating in professional organizations, which this one is a key item I'd like for you to remember. Nursing is the largest sector of public health professionals. So our professional organizations such as the ANA and NLN and other organizations like these provide us with the best way to actively advance public health initiatives. And also, you already are being politically active as a nurse when you advocate for your patient, identify a barrier, or speak up about a concern. So don't underestimate your influence. Patient-centered care means tailoring care to the patient's life, not forcing the patient to fit the plan. For Miss Johnson, a perfect care plan might include strict diet, frequent appointments, and medication adherence. But if she cannot afford medications or lacks transportation or lives in a food desert, place that doesn't have access to good, nutritious food, then the perfect plan is going to fail. So instead, we ask, what's realistic for her? That is patient-centered care. It's not about perfection, it's about practicality. Technology, especially telehealth, has the potential to improve access to care. For rural patients like Ms. Johnson, telehealth can reduce travel time, increase appointment access, and improve follow-up care. But here's the critical question. Does she have reliable internet? Does she have a device? Does she know how to use it? Because if the answer is no, technology can actually increase disparities. So again, the solution is not universal. It must be individualized. You see here that in Georgia, there was an initiative in 2019 called the Georgia Telehealth Act, which was created to widen the availability of telehealth services to Georgia residents, expanding access to care in rural and underserved areas where in-person services are limited or unavailable. So this is in direct relation to the COVID-19 pandemic that we experienced. My husband and I recently bought a farm in Talbot County, which is a very rural county in Georgia. They have very few resources, and the internet is not very accessible there. Um, Part of the another initiative in Georgia was to supply fiber access to allow for internet into the rural communities. And in this case, in Talbot County, they ran fiber and they have connected it all at no cost to the residents in the rural um, counties. Where my husband and I live in Monroe County, we had to pay for the installation of the fiber, not only to our home, but in our neighborhood. We had to pay and supplement the cost of it. So that's just an example of how funding in Georgia has addressed some of these disparities. We've talked about systems and technology. I want to shift your thinking a little further because this is where nursing starts to look very different from what you've experienced so far. Let's revisit the concept of public and population health nursing, which is a specialty practice. Instead of focusing only on the individual patient, it focuses again on improving the health of entire communities and population. This means we move from thinking one patient to groups of patients, communities, and systems that influence the health. As public health nurses, we are going to be working across a wide range of settings, including clinics, schools, homes, communities, organizations, and government agencies. And what's important here is that our practice doesn't stop at treatment. It integrates health promotion, disease prevention, policy advocacy, and community collaboration. So we're not just caregivers, we're going to be coordinators, advocates, and leaders within the system. So let's bring this back to Miss Johnson. If we only think as traditional nurses, we might focus on her blood sugars, her medication, and her diet. But as population health nurses, we are going to be asking what's happening beyond the hospital that's affecting her health. Maybe she lives in rural area with limited access to providers. She has difficulty getting transportation, and she may not have consistent access to healthy food. She may be struggling financially to afford her medications. So her health is not just about her diagnosis, it's about her environment, access, and resources. So let's look at the framework shown here on this slide because this is how population health work actually happens. First is strategy. This means having clear goals and plan. For Ms. Johnson, a strategy might include reducing uncontrolled diabetes in rural populations, increasing access to care in underserved areas. Next is people. This is about skills, roles, and teamwork. It includes nurses, providers, social workers, community partners. Because Ms. Johnson's care is not handled by just one person, it requires a team approach. And finally, processes. These are the systems and workflows that make care possible. For example, there has to be referral systems, care coordination, follow-up and outreach programs. Without good processes, patients like Ms. Johnson are going to fall through the cracks. So what does this mean for you as the nurse? It means your role is not just to treat the disease. Again, your role is to identify the barriers, connect the patient to resources, coordinate the care between the various team members, and advocate for change within the system. You're working within a system, but also helping improve the system. So when we're looking at Ms. Johnson, we're not asking why she's non-compliant. We're asking what barriers are preventing her from being successful. And that's going to shift from traditional nursing to population health nursing. Public and population health nursing is, again, looking beyond the patient to the system and communities and the conditions that shape their health. It's stepping in as the nurse to make the systems work better for patients like Ms. Johnson. So based on what we just discussed, think about one barrier that she's facing that cannot be fixed with medication alone. On this slide, we define public population health nursing, and we focused on improving health in entire communities and populations. And we highlighted strategy, people, and processes. Now, I want you to understand that this isn't just my opinion or a trend. This is a national expectation for professional nursing practice. So on the next slide, we're going to talk about AACN essentials. They have essentials for professional nurses, and they are competencies that nurses are expected to have when they enter practice. And specifically how nurses are positioned as collaborators and leaders. So that's very important. The AACN is an organization that outlines our competencies as professional nurses and that we must be collaborators and leaders in population health for patients like Ms. Johnson. Okay, so we're going to connect our role to the National Professional Standard. Again, the AACN essentials were revised in 2021, and they place population health as a critical domain of nursing competencies. In other words, being able to think and act at the population level is part of what it means to be a professionally prepared nurse. This is part of the competencies that you have to demonstrate before you are allowed to practice nursing. So, AACN defines population health as something that spans the full continuum from public health prevention all the way to disease management of populations. That means it includes what happens in community prevention efforts and what happens in clinical management because both shape outcomes. The most important part of this definition is that population health is collaborative. AACN explicitly says this work requires partnerships not only with traditional healthcare partners, but also with non-traditional partners. Included in this are affected communities themselves, public health, industry, academia, healthcare systems, and local government entities, all working together to improve equitable population health outcomes. So let's bring this back to Ms. Johnson. Ms. Johnson is not struggling with diabetes only because of biology. She is affected by the system around her, which is access to clinics, transportation, food options, affordability, and follow-up support. If we leave her to manage diabetes alone, we're going to keep seeing preventable complications. But if we take AACN's population health approach, and ask, who do we need at the table so Miss Johnson can succeed? That's going to mean partnering with community organizations to support nutrition access, working with public health or local services to reduce barriers, collaborating with clinics and care coordination teams to improve follow up, and advocating for policies that make equitable care possible. So AACN also outlines key areas of competence, what you must be able to do as a nurse in population health. And this includes managing population health, engaging in effective partnerships, considering socioeconomic impact, advancing equitable population health policy, and demonstrating advocacy strategies. So the bottom line, AACN position nurses as both collaborators and leaders in population health. You're going to see that again. We don't just carry out plans, we help design them, we connect systems, we use data, and advocate for change. So patients like Miss Johnson have a real chance at better outcomes. So based on this, Miss Johnson's barriers, which partner would make the biggest difference first? Public health, community organization, or local government? And what would you ask them to help with? And this is just your opinion. Public health nursing started because nurses recognized that treating illness alone was not enough. They saw that living conditions were driving disease. That same principle applies today to Miss Johnson. And we're going to be talking about visionary leaders such as Lillian Wald, who established a foundation for a new kind of nursing, one that was rooted in the community, driven by justice, and guided by compassion. So, who was Lillian Wald? You can find a lot of information here on the slide about her, but basically, she's considered the founder of public health nursing. She took nursing into communities. She focused on prevention, social conditions. She understood that health starts outside the hospitals, and that's exactly what we are learning to do today. So let's look at some of the challenges that we are facing today in public and population health nursing. These include chronic disease, mental health issues, workforce shortages, emerging infectious diseases. Miss Johnson represents one of the biggest challenges, chronic disease in underserved populations. These are complex issues that require system-level solutions. As a population health nurse, your role includes assessment, identifying community needs, planning, development of interventions, implementation, so delivering that care, which involves outreach, and evaluation, measuring outcomes. For Miss Johnson, you're going to assess her barriers, you're going to plan realistic interventions, you're going to implement and support, provide support, and connect her to support, and then you're going to evaluate your success. So why does understanding public health system organization matters? To help patients effectively, you have to understand the system. That includes where the resources exist, how the referrals work, how services are funded. Without this knowledge, patients are going to fall through the gap. It's complex and it's very difficult for patients to understand this information and navigate the system on their own. They depend on us. Public health is not just one organization, it's a network. It's going to include government agencies, community organizations, and non-governmental organizations. In Miss Johnson's case, she's going to interact with multiple parts of this system. This is a visual that shows how all the parts connect. So there's no single system that works alone. It's interdependent. So you'll have federal, state, and local systems interconnected to deliver services and protections across the populations. This visual again is showing that care is delivered at the federal level, the state level, and the local level. Each of these levels have defined responsibilities to ensure that public health functions, especially in situations such as when we experience the pandemic with COVID-19, but also it functions in instances such as chronic disease prevention. In the case of Miss Johnson, each level is going to affect her access to needed care. I'm going to walk us through this diagram in a little more detail, step by step. So this figure shows how the public health system in the United States is organized and how care flows from the top down to the community level. In simple terms, it shows who makes decisions, who provides the services, and how everything connects to support patients. At the very top, you see the U.S. Department of Health and Human Services. This is the highest level. This is where national policies are created, funding decisions are made, and major health priorities are set. Right below that is the Center for Disease Control and Prevention, or the CDC. Here, they track disease, create guidelines, provide national leadership. So these top levels set the direction for the entire country. From there, we move down to the state departments of health. At the state level, they take federal guidance, adapt it to the state's population, and then distribute resources. This is where national plans become actual programs. In the center, you see arrows that go back and forth. This represents governance and communication between the levels, which is very important. Public health is not just top down, it also involves communication both ways. So state give feedback to federal agencies and local communities inform state decisions. So the system is constantly adjusting. Now we move down to social services. This includes things like housing programs, food assistance, employment support, and financial services. This is a critical level because these are our social determinants of health. And if we think about Miss Johnson, if she's struggling financially or lacks food access or has unstable housing, her health outcomes will suffer. So this level directly affects her daily life, not just her medical care. Next, we have the local level where patient experience care. This includes the county and city health departments. This is where care becomes real for the patient. These departments provide screenings, they offer education, they deliver the vaccines, they connect patients to resources. This is the level where Miss Johnson actually interacts with the system. And then at the bottom, we see a large section labeled in collaboration with. This includes schools, housing departments, police and fire services, transportation systems, parks and recreation, and public utilities. This is one of the most important parts of the diagram. Public health does not work alone. Health is influenced by transportation. Can she get to her appointments? Education. Does she understand her care? Housing. Is it a safe environment? Is it stable? So improving health requires collaboration across many systems. So let's put this together using Miss Johnson. For her to be healthy, this system needs to work at every level. Federal funding and policies. At the state level, programs and services. At the local level, that's where her actual care is delivered. In social services, she needs support for her daily needs. And in the community partners to address real life barriers. If any part of this system is weak, she will struggle to manage her disease. So, the most important takeaway here is that health outcomes are not created by one provider or one visit. They're created by a system of organizations that work together. And if that system is not well connected, then patients will fall through the cracks. As a nurse, you're most likely are going to work at the local level, but you have to understand the system above you and the resources around you, the barriers your patients face, because your role is not just to provide care, it's to help the patient navigate this system. So when you think about Miss Johnson, don't think about just her disease or her diagnosis. Think about the system around her, because improving her health means improving how this system works for her. Let's move to talk about one of the most important factors that determine access to healthcare in the United States, and that's health insurance. Insurance is not just about payment. It directly affects whether patient seeks care, when they seek care, what kind of care they can receive. So understanding insurance is critical to understanding patient outcomes. In the United States, access to healthcare is not universal. It's heavily influenced by the type of insurance a person has or whether they have insurance at all. So let's start with the public insurance. This is government funded. There's three main types listed on this slide. That's Medicare, which covers adults 65 and older and individuals with certain disabilities. Medicaid, which covers low-income individuals and their families, and CHIP, or Children's Health Information Insurance Program, which covers children and families who do not qualify for Medicaid but cannot afford private insurance. These programs are designed to improve access for vulnerable populations. So let's think about Miss Johnson. She's a 52-year-old, so she does not qualify for Medicare yet. If she has a low income, she might qualify for Medicaid, but that depends on eligibility rules in her state. So if she does qualify, Medicaid could help her afford medications, primary care, and manage her chronic conditions. But if she does not qualify, she may have very limited options. Next, we have private insurance. This is typically employer sponsored or purchased individually. It's how most working adults in the U.S. receive coverage. However, there are challenges. The premiums can be expensive and the deductibles may be high. Some services may not be fully covered. So even with insurance, patients may still struggle to afford care. Miss Johnson works part-time, so let's think about that. Part-time jobs often do not provide insurance benefits. So she may not have employer-sponsored insurance or not be able to afford private insurance on her own, which means she may be uninsured or underinsured. So let's talk about patients who are uninsured. Millions of people in the United States do not have any health coverage. These individuals are more likely to delay care, skip medications, avoid preventative services, or use emergency departments instead of the primary care. And this leads to worse health outcomes. If Miss Johnson is uninsured, think about what that means. She may delay seeing a provider. She may not refill medications regularly. She may only seek care when symptoms are severe. And that explains why she might end up in the emergency room. Why her blood pressure or diabetes is uncontrolled. It's not just a medical issue, it's an access issue driven by insurance. I want to make this very clear. Insurance is one of the strongest determinants of health outcomes in the United States because it affects access, affordability, continuity of care. So when patients struggle with chronic conditions, we have to always consider their insurance status. As a nurse, you're going to need to think about more than just treatment. You're going to have to ask, can this patient afford the medication? Do they have coverage for follow-up care? Are there programs that can help them? Because if the answer is no, your care plan may not work. So take a moment and think about this. How might Miss Johnson's health outcomes change if she had consistent health insurance? Be specific. Would her ER visit decrease? Most likely. She may have a primary doctor. Would her medications improve? That's possible because it's very difficult to get your medications refilled if you're not going to the same provider and going routinely and regularly. Would her disease be better controlled? That is a good possibility. If she had access to care and proper medications, she would be able to have a better control of her disease. So when you look at Miss Johnson, remember her health is not just determined by her diagnosis. It's determined whether she has access to insurance. And in the United States, access to insurance often determines access to health. Okay, so let's move on to one of the most important and most debated questions in healthcare. And that is healthcare a human right? It's not just a philosophical question, it directly impacts how healthcare systems are designed. how care is delivered, and who is able to access the care. So even though this is a discussion topic, it has real consequences for patients like Miss Johnson. Globally, healthcare is recognized differently across countries. The Universal Declaration of Human Rights, established in 1948, identified health as a fundamental human right. This means that many countries structure their healthcare systems to provide universal access to care. However, in the United States, we do not have a universal healthcare system. Instead, access in healthcare is tied to employment, income, insurance status. And that creates variations in who can access the care. So let's first look at the argument for healthcare being a human right. These arguments focus on equity and access. The key points include health is necessary to live, work, and function. Without access to care, people suffer preventable illness and death. Most developed countries provide some form of universal coverage. So, from this perspective, healthcare should be available to everyone, regardless of income or insurance. However, universal healthcare costs a lot of money and someone has to pay for it. Now, let's think about Miss Johnson. If healthcare were treated as a guaranteed right, she would have consistent access to care. She would not delay her treatment. She would likely have better control over diabetes and hypertension. So, under this model, her outcomes would likely improve. But it's not that easy. Like I said, someone has to pay for that universal health care. So let's look at the argument against this. The arguments often focus on system structure and costs, and rightly so. Key concerns include the financial cost of providing universal care, the role of government in healthcare decisions, because if you give the government the power to make the decisions because they are funding universal health care, then they decide who would get care for what diseases or procedures, etc. There's also the belief about individual responsibility for health. There's disagreement on the best way to deliver care. So, from this perspective, health care should not be fully controlled or guaranteed by the government. Let's apply this perspective to Miss Johnson. In the current U.S. system, her access depends on insurance. Her care depends on affordability, and her outcomes depend on what services she can access, because health care is not guaranteed. She may experience gaps in the care. This debate is not just theoretical, it directly shapes how healthcare systems function. And the key connection here is if healthcare is not universally guaranteed, then access may become uneven. And when access is uneven, health outcomes are also uneven. However, with universal health care, as we will learn on future slides, access technically is available universally. However, there are long wait times for accessing the care. So is it really accessible? That's the question. Let's take a look at where public health is heading. This slide focuses on current trends in the United States, and the trends are important because they are changing how healthcare is delivered. As future nurses, you'll be practicing in this evolving environment, and these changes will directly impact patients like Ms. Johnson. First, we see a shift toward data-driven population health. This means that healthcare systems are increasingly using electronic health records, data analytics, population tracking systems to identify who's at risk, what conditions are increasing, and what interventions are needed earlier. Instead of waiting for patients to get sick, systems are trying to predict and prevent problems. And this has historically been a more cost-effective way of dealing with illness and rising costs of healthcare. For Ms. Johnson, this could mean healthcare systems identify patients with uncontrolled diabetes, they track missed appointments or ER visits, they intervene earlier with outreach or support. So instead of reacting to her conditioning, um, her condition worsening, the system could step in sooner to prevent the complications. The second major trend is a stronger focus on health equity. After events like COVID-19, it came clear that not all populations experience health the same way. So now healthcare systems are prioritizing reducing these disparities, improving access, addressing social determinants of health. The goal is to ensure everyone has a fair opportunity to achieve good health. For Ms. Johnson, this is important. She represents a population that may experience disparities due to her rural location, limited access to care, and financial challenges. So, increased focus on equity could lead to more targeted programs, greater support for rural communities, and improve access to services, all of which could improve our outcomes. The third trend is a shift toward prevention instead of treatment. Traditionally, healthcare is focused on treating disease after it develops, and now there's a growing emphasis on preventative chronic disease, promoting healthy lifestyles and addressing risk factors early. The idea is to reduce disease before it becomes severe. With Miss Johnson, we see why this matters. She already has diabetes and hypertension, so treatment is necessary, but prevention could have made a difference earlier in her life. And even now, prevention can still help prevent complications because we know that with diabetes and hypertension, they're at high risk for chronic kidney disease and end-stage renal disease. So, um, ex- providing education on diet, regular monitoring, community support, the goal becomes preventing worsening, not just managing the disease. Key idea to take away here is that healthcare is shifting from reaction to prevention and prediction, from treating illness to identifying risk early, to addressing inequalities, to improving outcomes at the population level. And as nurses, you're going to play a role in all of these trends. You'll be able to use data to identify high-risk patients, advocate for health equity, focus on prevention and education, and most importantly, you'll help bridge the gap between healthcare systems and patients like Ms. Johnson. These trends represent the future of healthcare, and for patients like Ms. Johnson, they're not just trends, they're opportunities to improve health outcomes and reduce her disparities. Let's look at how healthcare systems work in different developed countries. This is important because it helps us understand how system structure affects access, how it affects costs, and ultimately how it affects patient outcomes. As we go through each system, I want you to keep asking, how would Ms. Johnson's experience care in this system? Let's start with the United Kingdom. The UK uses a single payer system called the National Health Services. Some pros for this type of system is that healthcare is free at the point of care and everyone has universal access. Costs are generally lower overall. However, con is there's often long wait times for procedures and to see specialists. The system faces funding and staffing challenges. Next is Canada. Canada has a publicly funded universal system managed by provinces. Again, the pro is universal coverage for essential services, and there is a strong focus on equity and access. Cons, again, long wait times for non-urgent care, and not all the services are covered, like medications and dental. In Germany, they use a multi-payer system where everyone is required to have insurance. Some pros are broad access to care, high quality services, and there's a strong coordination of care. However, there's higher overall system costs, and it is a very complex system due to multiple insurers. And there's financial pressure from an aging population in that country. In the United States, where Ms. Johnson lives, currently the U.S. uses a mixed system combining public and private insurance. The pros here is access to advanced technology and specialized care, greater flexibility and provider choice. Cons is that there is no universal coverage and many people are uninsured. There are still high healthcare costs and there are significant barriers to access based on income, insurance, and geography, location. And despite the high costs, we in the United States do not have better overall health outcomes compared to other developed countries. So the issue is for Miss Johnson, would she be better off in any of these other countries? You'd have to really think about her specific situation. She needs to see a specialist. Would she have access to these specialists if she lived in a country that had universal health care or required insurance to be purchased by the individual? Would the long wait times be a problem? Would medications be paid for? Every one of the systems have different pros and cons. A comparison of health spending across different developed countries. So each country is listed on the bottom. The vertical axis shows how much is spent on healthcare per person. The key is the legend at the bottom. Filled circles equal the total spending. The diamonds equal the government or compulsory spending, and X marks are voluntary or private spending. So this chart is not just showing how much is spent, it's showing who is paying for the health care. So key observation number one is the United States stands out. If you look all the way to the right side of the graph, you're going to notice that the United States spends the most per person on healthcare. It is significantly higher than every other country. One factor that contributes to this higher overall healthcare costs is the U.S. is the administrative costs and the price for medical services and prescription drugs are higher here in the U.S. This is one of the most consistent findings in global health comparisons. The U.S. spends more but does not always achieve better outcomes. Now let's think about Ms. Johnson. Even though the U.S. spends more, she still struggles with access. She may delay care. She may not afford medications. So this tells us something important. High spending does not automatically mean better patient outcomes. So let's look at the breakdown of spending for each country. You're going to notice that many countries have a large portion of government or compulsory spending and a smaller portion of voluntary or private spending. This means that in countries like UK or Canada that the government plays a larger role in the US. There is a much larger share of private spending in contrast. For Ms. Johnson, this is critical because in the US, her access depends more on private insurance or out-of-pocket costs, which means she cannot afford the coverage. If she has limited insurance, she is more likely to experience barriers to the care. As you look across the chart, many countries spend less than the US, but those countries often have universal coverage, more consistent access, better population level outcomes. And this reflects a different system design, more centralized, more shared cost across population. If Ms. Johnson lived in one of these countries, she might have more consistent access to care. Up to this point, we focused on primarily on healthcare systems within the United States. But now I want you to think bigger. Public health is not just national, it's global. This means health problems across borders. Solutions often require international collaboration. And what happens globally can impact local communities. So, understanding global public health helps you become a more effective nurse. First, we have the World Health Organization, or WHO. The WHO sets global health priorities, coordinates responses to health emergencies, and provides guidance during outbreaks and crises. For example, during pandemics, the WHO helped countries respond in coordinated ways so that the organization plays a key role in protecting population health worldwide. Next, we have the Sustainable Development Goals, also called SDGs. These are global goals designed to improve health and well-being. One of the most important for us is the SDG number 3, which is good health and well-being. This goal focuses on expanding access to health care, reducing health disparities, and improving overall population health. The ultimate aim is to move toward universal health coverage globally. So let's bring back Ms. Johnson. At first, it may seem like global health has nothing to do with her, but it absolutely does. Why? Because global health priorities influence national policies, funding decisions, and public health strategies. For example, the push for health equity and access globally also influences programs here in the U.S. So, improving global health systems can lead to better local outcomes for patients like Ms. Johnson. This slide also highlights an important role nurses as global citizens. Nurses can contribute to global health through medical mission work, like what happens with our Mercer on missions, public health initiatives, policy advocacy, disaster response. And this is something you already are connected to through experiences like global community outreach programs. Nursing is not limited to one setting, it has a global impact. So let's think about Ms. Johnson again. Her challenges, like chronic disease, limited access to care, and social determinants of health. These are not unique to her. These are global issues. Patients in other countries face similar barriers, similar disparities, and similar challenges in managing chronic illness. So, understanding global health helps you realize that Ms. Johnson's situation is part of a much larger pattern. So, remember this health is interconnected globally. Diseases can spread across countries, and health policies influence multiple systems. Solutions often require collaborations across nations. So, improving global health improves local health outcomes. Take a moment and think about how global health efforts like improving access to care or reducing disparities can benefit patients like Ms. Johnson in your community. Think beyond geography, think system wide. As future nurses, your role is not just clinical. You're going to be advocates, educators, and participants in a global health system. Understanding global health prepares you to address both local and population level health challenges. It's not going to be an isolated issue. What happens globally is going to influence what happens locally. And improving systems worldwide ultimately is going to benefit patients like our Miss Johnson. As we come to the end of this lecture, I want us to go back to where we started. Miss Johnson is the center of everything because everything we discussed today ultimately connects back to her and patients like her. Let's remind ourselves, Ms. Johnson is a 52-year-old with diabetes and hypertension with limited access to care. She has some financial constraints and she lives in a rural community. At the beginning of the lecture, it may have seemed like a simple chronic disease case, but now you should see something different. Ms. Johnson is not just a patient with a diagnosis. She's impacted by social determinants of health, access to care, insurance coverage, public policy decisions, healthcare system structure, community resources, and even global health priorities. So instead of asking what's wrong with her, we are now asking what is happening around her that's affecting her health. So the key ideas are from this lecture are number one, social determinants of health, which include income, environment, education, and others, and how they affect her health. These impact her ability to manage her disease. Number two, health disparities. She may experience worse outcomes due to her location and resources available. Number three, health equity. She does not need the same care as everyone. She needs care that fits her situation. Number four is policy and systems. Her access is influenced by decisions made at the federal, state, and local levels. Number five, insurance and access. Coverage determines whether she can afford treatment. Number six, global and population health thinking. Her situation reflects broader patterns of health inequities. This is a population health in action situation. So clearly, need to understand that Miss Johnson's health is not determined by her diagnosis alone. It's determined by the system she lives in, and if that system has gaps, her outcomes are going to be affected. Your role is to recognize these barriers, identify system level issues, adapt the care to the patient's needs, connect the patient to resources, advocate for change, because your responsibility is not just to treat a disease, it's to improve the patient outcomes within the real world systems.